Warm welcome to all of you. My name is Marinetta Lehn. I am the product manager for surgery and implants at Unident Nordic. And a special warm welcome to Dr. Kristina Bertl, who will share her experience with the great concept of clean and seal from Regident. Just some information. Please make sure you are muted. If you have any questions, please type them in the chat. And this lecture will be recorded for you to watch up to 2 months afterwards. So, Kristina, the stage is yours.
Dear Marinette, thanks for the introduction. I will share my screen. Now you should be able to see the presentation, or? Does it look good? So my name is Kristina Bertl. As Marinette said already, I'm a periodontist from Austria, but I live now already since 10 years in Sweden. And I work part-time at the specialist clinic in Karlskrona in Blekinge and part-time at the university in Vienna. So it's a bit complicated. But let's not lose more time on that. Let's go directly into the topic because we have a very interesting and big topic, but only a little bit of time now in the lunch break. So let's start directly with our topic, how to minimize or even avoid surgery in periodontitis and peri-implantitis cases with the clean and seal concept. So we will address both topics, periodontitis cases and peri-implantitis cases. And we know for both, for the treatment of both diseases, we have actually quite up-to-date guidelines from the European Federation of Periodontology. But there was something missing in these guidelines, and that is the use of a product with hyaluronic acid. In the beginning, a few words on hyaluronic acid. What is hyaluronic acid? It is a glucosaminoglycan, and it has a very high viscoelasticity and a very high hygroscopicity. What does that mean? Just to give you an idea or an example. 1 gram of hyaluronic acid binds up to 6 liters of water. Or another example, all of us have hyaluronic acid in our body. So for an average person of 70 kilogram has roughly 15 gram hyaluronic acid distributed all over the body. And what is kind of interesting, then about 1/3 of this hyaluronic acid is replaced and turned over every single day. Many of us might know hyaluronic acid from a different parts or from different aspects, such, for example, from skin and hair products. Because if you, for example, Google skin and hair products and hyaluronic acid, we find a huge variation of different products. So it is used in dermatology quite a lot. But hyaluronic acid is not only present in the skin and in the hair, it's, for example, also present in the eye, it is present in the connective tissue, and it is also present in the gums. If we use now products with hyaluronic acid, it's always an important question so that we also know if we want to explain it to our patients, how is hyaluronic acid actually produced? In the beginning, hyaluronic acid was produced with from the rooster comb, but that had a little bit the problem. Then you had some animal proteins in the product, and it had the risk of an allergy. So the production switched now completely to a fermentation process with streptococci. So in all the products which we are using nowadays, there's no risk anymore for any allergic reaction due to animal proteins. What are now the properties of hyaluronic acid, or why has hyaluronic acid become so interesting also for us dentists? It has quite some nice properties. For example, it's bacteriostatic, it's anti-inflammatory, it's osteoinductive, it's pro-angiogenetic, it promotes in general the wound healing, and it has been even shown in the last years that it can promote periodontal regeneration. And all these properties, if you think about it, make it a quite interesting product for us. So let's get more into the topic, and let's start with the periodontal part and how to treat periodontitis cases with the clean and seal concept. Just very shortly now in the beginning, a short overview on the S3 guidelines on treating periodontal disease. We all know that it was distributed now or scheduled basically in 4 steps. And the first step when treating periodontitis patients should always be the reduction of risk factors and teach the patient in an adequate oral hygiene practice. either with a manual or an electric toothbrush. And then, of course, most of our patients we really have to teach with interdental cleaning. This first step is followed by the second step, which is the main treating part, a non-surgical treatment or the cause-related therapy, where we perform the supra and subgingival debridement. This step is evaluated in the third step, and then if some sites are not responding well enough to the treatment, we might continue with another round of non-surgical treatment or with some surgical treatment. And finally, if all the treatment was successful, we schedule the patient into supportive periodontal care. If we jump now directly into the second step, into the subgingival instrumentation. Subgingival instrumentation can be done with ultrasonic devices or with hand instruments. And what can we approximately expect if we think about the non-surgical treatment part? On average, after about half a year, we can expect on average a pocket depth reduction of 1.5 millimeters. If we look only at the deeper sides, we can expect approximately 2.5 millimeters, so already a bigger reduction. We get quite a nice reduction of bleeding and probing. And what we can see here, this non-surgical treatment is a very efficient treatment because on average, 3 out of 4 sites are closed and healed already after this non-surgical treatment. However, in turn, that lets us also with 25% residual pockets, which are not perfectly treated. And unfortunately, we all know that residual pockets, especially on the long term, increase the risk for further tooth loss. So we would like to achieve a perfect treatment result in all of the sites, not only in 75% of the sites. So it is since many years, or I would say even decades, it's always discussed whether we can do something additionally to the or additionally to the mechanical debridement, whether we can put something locally or whether patients can get some pills so that we further improve this outcome. And if we look now again very quickly and very roughly into the EFB guidelines, they have investigated different possibilities of adjunctive treatment to the non-surgical debridement. But basically, they only recommend 2 treatment possibilities. That is on the one side, the locally administered sustained released chlorhexidine or the locally administered sustained released antibiotics. Those are actually the only 2 where the EFP said we have enough evidence and we have enough studies to really say we get an additional benefit for our patients. But something was missing in these guidelines, and that is a product which has been coming up more and more now the last years. And that is, those are products containing hyaluronic acid. What is now the idea with hyaluronic acid or with a gel containing hyaluronic acid? The idea is to treat, for example, patients like the one what you can see here now on the screen. You have a tooth with a residual pocket of 5 millimeter and with bleeding and probing. Then, of course, one has to redebride the site with ultrasonic devices and or hand instruments. And then one can apply a gel containing hyaluronic acid. One might even tell the patient to use a product with hyaluronic acid on the interdental brushes. And in best case, the patient comes back after, for example, 3 months, and we have a 4 millimeter pocket, which is not bleeding, meaning a healed site. We have now quite a while ago, I think it's now about 8 years ago, tried to summarize the literature on hyaluronic acid and to assess how big is the effect if we use hyaluronic acid additionally to non-surgical and surgical treatment. And if we look now on the results on non-surgical treatment, we could at that time point identify 10 different studies. However, those studies were quite different. These 10 studies used 6 different products. They applied the product once or 5 times per day, 1 or 60 times in total. They applied it only supragingival or subgingival or both. So we could not really do any meta-analysis to really combine the data. Nevertheless, what we could see is that basically all of the studies showed some advantage in favor of the product of hyaluronic acid. for example, 2 to 20% more reduction in bleeding or probing, or 0.2 up to 0.9 millimeter more reduction in pocket depth. But as I said now, when telling you about the results of the systematic review, I told you this is now already about 8 years ago, and there are now quite some new studies and also a new concept. And that is what our webinar today is actually about, the clean and seal concept. What is it? How can we apply it? And what can we expect when using it? So the idea of clean and seal concept is to combine actually two products. So we identify the residual pocket, and then we start with a new cleaning process. And that is now the clean part of this concept, using peri-solve. Peri-solve is a 0.5% sodium hypochlorite, which is mixed with amino acids. And before starting the debridement, you place peri-solve into the pocket and you let it there for 60 seconds. So you just wait for 60 seconds so that the product can actually act on the biofilm and on the granulation tissue. And then you start the cleaning process. So you inject first peri-solve, then you wait for 60 seconds, and then you perform the debridement. How big is the effect of this first part of the clean and seal concept? So how big is just the pure cleaning part, or the additional cleaning with peri-solve? There's one study available which included 40 untreated periodontitis patients, and they made a regular debridement with or without peri-solve. And they followed the patients up for 6 months. And if we just look now into one of the outcome parameters, which is one of the most important outcome parameters, and that is how many residual pockets we have left, there we can see quite a difference between the two groups. In the group with peri-solve, there were only 2.2 residual pockets left, but in the control group, the number was 3 times bigger, 7.3%. So just with using the peri-solve, we get already better outcomes after the non-surgical treatment. Another part which is important when you want to start to use the product is that you should mix the peri-solve, because it comes with 2 syringes, and then you connect the 2 syringes and you mix it. And this mixing should be done only immediately before applying it, or let's say up to 20 minutes. So that was a study which was testing for 20 minutes and even longer, how long the bacteriostatic effect remains from peri-solve. And there I could see that after 20 minutes, the effect of peri-solve gets less. So it is not recommended, to prepare in the morning maybe 5 syringes and use them during the day. The recommendation is to really just mix it immediately before you use it in the patient to get the optimum result or the optimum effect out of it. And then an important part is also this cleaning process should not be done only once. It should be done 2-3 times. So that means you inject the peri-solve, you do the mechanical debridement. Then you inject it again and you wait again 1 minute. And then you do again the cleaning process. And then a 3rd time. So it is not something what you just do once. You should do, the recommendation is to do it really 2 to 3 times to completely remove the biofilm and also the granulation tissue. And when you are done with that part, so when you are satisfied with your debridement, before the patient leaves the office, you apply the seal part of this concept, and that is Hyadent. And Hyadent is gauze-linked hyaluronic acid. The advantage of gauze-linked hyaluronic acid is that it's supposed to stay longer in the pocket and is less fast resorbed compared to products with hyaluronic acid which are not gauze-linked. And then you follow the patient up as we actually know it from the guidelines and as we know it from our daily clinical life. What is maybe also, if you want to start using the product, what is a nice tip or a good effect which is good to know is that you can store the ampoule, because if you get Hyadent, you get 1 package with 2 ampoule of hyaluronic acid. And you use 1 for 1 patient, but then you can store this ampoule in the fridge up to 3 months. And for example, if the patient comes back after 3 months, you can reuse the same ampoule for the same patient. So you can use the same ampoule 2 or 3 times for the same patient. And that, of course, saves the patient a little bit of money. That is, I think, quite nice and important to know. But what is now the effect of this combined concept? So what is the effect of clean and seal? And there are now in the last, I think, 2-3 years, there have been popping up 3 very nice publications on this concept. Let's start with the first one. The first one was a randomized controlled clinical trial, and they were comparing scaling and root planing versus scaling and root planing with the clean and seal concept. They had 48 patients with untreated periodontitis, and they followed the patients up for 6 months. Let's go directly into the results. So you have here now on the left, just the scaling and root planing, on the right, scaling and root planing with the clean and seal concept. And you can see quite a difference. For example, the pocket depth reduction was 1 millimeter better in the group receiving the clean and seal concept, so 1.8 versus 2.9 millimeters. Similar in the gain of clinical attachment. Again, about 1 millimeter difference between the groups. And if you think about it, and if you think a little bit about the numbers, what I told you in the beginning, that we can on average expect 1.5 up to 2.5 millimeter improvement, then 1 millimeter difference is actually quite a lot. And if one, just to give you an idea, an example, if one is comparing a new product or evaluating a new product, one always says the difference to the standard treatment should be at least 0.5 millimeter to be able to say that I have a clinically relevant improvement, not only a statistically significant one, but also a clinically relevant one. And that here you can see even a difference of 1 millimeter. For example, also the bleeding and probing was almost only 1/3 in the test group, so with clean and seal. And then also a very important parameter, the number of sites with residual pockets after 6 months was only 1/3 in the test group with clean and seal compared to scaling and root planing. And we all know that those are the sites which otherwise might need surgical treatment. And then, of course, if you have here just 1/3 of the sites, it's a clear benefit for the patient. So one can expect quite a difference between this control and test group. The same study did not assess only the clinical outcome. They also looked into the colonization with periodontal pathogens. And you can see here on the left side, the baseline. And then you always have first the control group and then the test group, and then 5 different typical periodontal pathogens, like Porphyromonas gingivalis, Tannarella forsythia, Treponema denticular, and so on. And after 6 months, the numbers, what you can see here, that is the detection frequency. So how often could they detect one of these 5 pathogens in a patient? And for 3 of them, for Porphyromonas gingivalis, Treponema denticular, and Prevotella intermedia, they got a significant higher reduction in the test group. So you can see here, for example, in the control group, it was still present, or Prevotella intermedia was still present in about 46% of the patients, but only in 8% of the test group. Then what is always what we would like if we treat periodontitis patients? We want to have on the one side, of course, closed pockets. But in best case, we do not want to have just a long junctional epithelium. In best case, we want to have periodontal regeneration because then we know that it's more stable on the long term. And this third publication, which just appeared now, I think 1 or 2 months ago, is a very interesting preclinical model where they took dogs, they extracted the teeth, and they created periodontal defects, as you can see in the upper line here. So they exposed the root, they put a thread here, and they created chronic inflammation and a periodontal defect. So you can see here the deepened pockets after inducing the periodontal defect. Then they performed the clean and seal concept. So they applied Perisolve, they debrided the site, they repeated the process, and in the very end, on the lower right side, they applied the hyaluronic acid. And I have here now 2 examples of the histology of the study, the control group and the test group. And I don't want to go now into detail with the histology, But just to give you an idea, if we compare on the left side now the control group with on the right side the test group. In such studies, one always makes a small hook on the root so that we know how deep was the defect in the beginning. Here we can see that that is for both examples on the same level. And up here, you have approximately the cemento-enamel junction. And in the control group, they gained back a little bit of bone, represented by the blue line. But if you compare it with the test group, the alveolar crest was much higher compared to the control group. So you got a higher amount of regeneration, a higher amount of new alveolar bone, new cementum, and new periodontal ligament. And that is also represented in the tables with the numbers. For example, if we just take now 2 or 3 out of the whole table, if we look at new cementum and new attachment, we can see that the number in the test group using the clean and seal concept is 3 times higher compared to the control group, which just received debridement. Now, so if we look at the new bone, what I have shown you on the histology before is again 0.8 millimeter difference. So that is quite a clinically relevant difference, and it proves that hyaluronic acid, a little bit similar as we know it, for example, for enamel matrix derivatives, has the potential to really induce periodontal regeneration. But we can use hyaluronic acid not only in the second step, we can actually also use it for residual pockets in the third or in the fourth step of treatment. So if we look, for example, for studies using hyaluronic acid or the clean and seal concept in the fourth step of treatment, so the patient is actually already in supportive treatment, but might have a small relapse and is presenting again with residual pockets. What is available so far for these patients is just a case here, a retrospective one, but what they could see after applying the clean and seal concept, first the periosolve, the debridement, and then the hyaluronic acid. What they could see is that in general, they got quite a nice pocket depth reduction, exceeding on average 2 millimeters, and they got quite a nice bleeding and probing depth reduction. And pocket closure in about 1 out of 4 cases, just with this single redebridement. We did ourselves one study with hyaluronic acid, not with the clean and seal concept, but just to show you a little bit the concept of what is available on the efficacy of hyaluronic acid. So we recruited patients undergoing supportive treatment, but having some residual pockets, and we wanted to assess the pure effect of hyaluronic acid. So we're comparing redebridement with or without hyaluronic acid. And then we followed the patients up for 12 months. So we identified the residual pockets, we debrided them, and then we applied a gel, and the patients additionally applied this gel at home with interdental brushes. And what we could see in general, the patients say it's quite easy to apply and is well accepted. And we had a clear tendency to have fewer residual sites after these 12 months. And this also has been shown for a very similar study using the higher dent product. They also saw a clear tendency for improved results with the hyaluronic acid. But what is now, for example, the product what we are using was a non-Gauss-linked hyaluronic acid. And what is the advantage of higher dent? It is a Gauss-linked hyaluronic acid. And as I said it already shortly in the beginning, the Gauss linking allows the product to stay longer at the spot. So it is less quickly resorbed compared to non-Gauss-linked hyaluronic acid. Nevertheless, we have to be honest and say we might improve for some patients or for many sites the results, but some sites may still not heal. And even if not the topic of today, I would just like to show you that one can also use this product when performing surgeries. So you see here a residual pocket of 6 to 7 millimeters, and you can see a clear vertical defect at the mesial part of the tooth 3-2. Now the video is a little bit faster because I said it's not really the topic of today's webinar, but one can use this product also for periodontal regeneration. So if we perform regenerative surgery, we performed here an entire papilla preservation technique. So we did not incise the papilla at all. We debrided the defect. It would be nice if it would always go so fast in the clinic as well. And then after we were happy with the debridement, we applied the hyaluronic acid into the defect, a little bit similar as we know it from enamel matrix derivatives. So you can see here, but the big advantage is You do not need to care about the bleeding because hyaluronic acid loves the bleeding. So it really is stabilizing the blood clot. And then sometimes we add a little bit of a collagen sponge just to stabilize the whole defect a little bit more. Then if you look at the results, 1 week postoperative, you see already a nice soft tissue healing. And then 9 months postoperative, you see shallow pockets of only 2 to 3 millimeters and a clear defect fill on the X-ray. So if we summarize now the first part under the periodontal cases, then we can see hyaluronic acid is a natural occurring substance. The clean part, PeriSolve, improves the removal of the biofilm and the granulation tissue. And the higher dent, the seal part, improves the periodontal healing. There are studies reporting a clinical benefit of up to 1 millimeter, and we have indeed histological proof of periodontal regeneration when applying this concept. Let's switch now in the last 10-15 minutes to peri-implantitis cases and how one can use the clean and seal concept in peri-implantitis cases. And again, we know that we have quite up-to-date guidelines for the treatment of peri-implant diseases. And they are structured into prevention, treatment of mucositis, non-surgical and surgical treatment of peri-implantitis, and supportive care. Of course, I will not go now into detail, but I would like to put your attention on 2 aspects which I think are really of utmost importance when treating peri-implantitis diseases. That is, on the one side, that we should really aim for early diagnosis. Can show you a case which was early diagnosed and referred to our clinic. And you can see here already the beginning vertical defects at the implant. And when taking off the bridge, one can see clear signs of inflammation and deepened pockets. This patient was just treated non-surgically. And due to the early diagnosis, we get a complete, just with a non-surgical treatment, complete resolution of the inflammation clinically, but over the years also a complete reosseointegration and a complete defect fill, just with non-surgical treatment. Unfortunately, it doesn't happen so often that we get this patient so early for treatment. So the disease resolution, what we can expect on average after non-surgical treatment of peri-implantitis is just somewhere between 15 and 47%. So not even every second patient. And the second aspect which I would like to put your attention on is that one really always has to check that the patients have a good access for oral hygiene. So for example, if we get a patient like that, where the prosthesis is just pressed on the gums, and just by looking at it, one can already see this patient cannot anyhow use interdental brushes. One really has to modify the prosthesis, and one has to give the patient a chance to actually keep the implants clean. If we look now what the guidelines say on the non-surgical treatment of peri-implantitis, then as expected, the non-surgical treatment should be always the first part of the treatment. And we should always start with the non-surgical treatment and then evaluate the results after 6 to 12 weeks. As I said now already, we have to improve the oral hygiene, we have to control risk factors. It's quite the same as for periodontitis cases, and we have to check whether we have to modify the prosthesis. The guidelines had a little bit of problems that the evidence on peri-implantitis treatment is much less compared to periodontal. Peri-implantitis much less than on periodontal treatments. So the only recommendation what they actually give is that one can use curettes and or ultrasonic devices. And the routine use of systemic antibiotics is not recommended. Again, we can ask now the question, what was missing in the guidelines? And here we come again, what can we do with hyaluronic acid in peri-implantitis cases? So the idea would basically be the same. We have a deepened pocket with bleeding. We perform a non-surgical debridement, either with ultrasonic devices or curettes, or also with air polishing devices. We apply gel, and in best case, the patient comes back with shallow pockets and no bleeding on probing. But how could we apply now the clean and seal concept in peri-implantitis cases? In general, the concept is the same as I presented it to you for periodontal treatment, for periodontitis cases. So one starts with the cleaning gel, one puts the gel for 60 seconds, one debrides the implant surface as good as we can. And then one important difference is we all know that the implant surface is often moderately rough structured, and it's much more difficult to clean compared to a root surface. So here the recommendation is actually not just 2-3 times to repeat this cleaning process. The recommendation is actually to repeat it 5 to 6 times at one implant. So that one really puts the Perisolve, waits 60 seconds, and then debrides the implant surface and really tries to remove also all the granulation tissue. And this step should be repeated 5 to 6 times with the background that we know that the implant surface with all the threads is more difficult to clean compared to a tooth surface. Then in the end, again, the gauze-linked hyaluronic acid and the regular follow-ups. How can it look like now in the clinic? I can show you here a case which was referred to our clinic. If we look at the X-ray, unfortunately, this patient was referred much later than the one case which I showed you just a few minutes ago. So when I took off the bridge for the one implant, I had no chance anymore to keep it. And you can see how nice the calculus has accumulated here on the palatal aspect. But the idea was it is a 95-year-old lady. And the idea was a little bit to keep the distal implant and maybe then keep the construction with a mesial extensioner and to avoid additional surgical interventions or something similar. So we had to remove the first implant because it was already completely deosseintegrated. It came out with the bridge. But then we said we go for the clean and seal concept and try to get this distal implant free of inflammation. In general, for peri-implantitis cases, I always recommend to take off the prosthetic restoration because you get a much better access to clean the implant surface. You start again with placing the Perisolve, what you can see here on this picture, and then you debride it. Then you repeat this process, as I said before, 5 to 6 times. And then often you really get out a lot of the granulation tissue. So the Perisolve does not only help you to remove the biofilm, it also helps to dissolve a little bit the granulation tissue, which can be, especially around implants, quite nice. Then in the end, you put the hyaluronic acid. And in this case, I put for the healing phase just a healing abutment, and it was fine for the patient. Then you can see after 1 month how nicely actually the site is developing. So if one looks now at the site, one can see clearly less inflammation. One can see pink mucosa around the implant and only shallow pockets. It became even better over time. So that is, for example, then the follow-up after 3 months, but then the patient also got finally the prosthetic restoration with a mesial extension back. What one could maybe discuss for this case, if you look exactly, she has actually no keratinized mucosa, so it would be maybe nice to do a mucogingival surgery there to place a free gingival graft. But as I said before, the patient is 95 and she actually is not really interested in that. But we managed with just 2 sessions to get this distal implant actually inflammation free, and she is now happy with the restoration. Scientifically, we have to admit that there's so far only very limited evidence regarding the clean and seal concept and treating peri-implantitis cases. I know from some colleagues that they are right now performing some studies, but the results will hopefully follow soon. What is important if you think now about the clean and seal concept and treating peri-implantitis cases? Let me show you another case. If we look now at the distal implant, where you can see after taking off the implant restoration, clear signs of inflammation, directly some bleeding. You can see on the X-ray clear bone loss, exceeding already the smaller threads from this Astra implant. And we can see deepened pockets of about 7 millimeters. Again, if I maybe go once back, if we look at this X-ray, those are the cases where I think, or where I try to handle them non-surgically. If there is a clear defect, but it's still on an extent where I think that can be handled non-surgically. Same as before, one is applying Perisolve, one is debriding, one is repeating this process 5 to 6 times, and one applies higher dent. And here we see the patient and after 2 months. You can still see some bleeding, but you can see the tissues are much, much better than at baseline. And the tissues are already quite tight around the implant again. And it's just 4 millimeter pockets left, but there's still some tendency to bleeding. And as I said it, peri-implantitis cases are much more difficult to treat. And there you just have to think, you just repeat the process. And there it's quite nice what I said before. You keep the higher dent in the fridge, you put the personal number of the patient on it, and then when the patient comes back after 2-3 months, you just repeat the same process with the peri-solve, with the debridement, and replacing the higher dent. What we have, for example, for this patient now planned, because it's also a little bit a similar problem as for the other patient. If you look exactly, the patient is lacking completely the attached mucosa in that area. So after reducing the inflammation or controlling the inflammation with the clean and seal concept, this patient will get now a mucogingival surgery and a free gingival graft on the buccal aspect in order to improve in order to improve the soft tissues and in order to make it more simple for the patient to keep it clean. Again, similar as before, I would like to show you that the product higher dent is not only functioning non-surgically, because again, we will have some sites, especially also with peri-implantitis, which will not be completely controlled with only non-surgical treatment. And there we have also the possibility to use it intrasurgically. You can see here a patient with a massive inflammation with pus and bleeding and swelling at this implant in the front, and with quite an extended bone loss of 50 to 60%. And again, a little bit speeded up the surgical video after the non-surgical treatment. And you can see how big actually this defect that this implant was. But the patient wanted to try everything to keep it, because it was a bridge on 3 implants from the tooth 1-1 to the second quadrant. So it was important for the prosthetic restoration to keep this implant. So what we performed, as the defect was actually too wide to regenerate it completely, we performed implantoplasty in order to make the surface less prone to biofilm accumulation. We used water peroxide to clean it chemically, and then we used such a collagen sponge and filled it with hyaluronic acid. So we just basically impregnated this collagen sponge with hyaluronic acid. We placed the hyaluronic acid around the implant and put this sponge on top of it. And then the patient in the healing process. This is now after 1 year. And if you think how the patient was looking in the beginning, it is maybe not the best aesthetically outcome, because for that, the defect was simply already too extended, but you can see that the tissues, there are shallow pockets, there is no inflammation, there is no bleeding, it's a nicely pink mucosa, and the patient is getting now a new bridge on this implant, because as you can also see, the prosthetic fit of the bridge is not the best, but there she's getting now a new restoration. If I summarize now the part on peri-implantitis cases, then we again, similar as before, hyaluronic acid is a naturally occurring substance and it has no risk for any allergic reaction, as there are no animal proteins in those products any longer. With the peri-solve, especially around implants, you can really remove quite nicely the whole granulation tissue, and then you seal it again with the higher dent. And as I said, the scientific evidence will hopefully follow soon. And we're also planning a study to do in Sweden, one on the real effect of this product in the non-surgical treatment of peri-implantitis. So with that, I'm at the end of my presentation. And yes, I think we have about 5 minutes left. If there are some questions, just open your microphone and feel free to ask.
Do we have any questions?
You're also welcome to write it in the chat.
I would like to say, dear Kristina, thank you so very much for this great lecture. And dear participants, thank you for joining. And if you don't have any questions now, you can always come back to us, to me, or to my colleague Marie Månsson for further questions and information. And I know Kristina, she will help me if we cannot answer your questions.
We can fix that, yeah.
Am I right, Kristina?
Exactly.
So thank you so very much all, and have a lovely day.
Have a nice afternoon.
Bye-bye.
Bye-bye.